Professor. I'm going to pass this on to my discussants now. Can I invite Serdar, Hans-Jörg, Apostolos, Ignacio, Marco, and Yuri to further discuss the session and try and make some better understanding of how microcirculation exists and what are the outcomes.
I'd like to ask Professor Idris, is there any... Okay. Yeah. Is there any correlation in between the sufficiency of microcirculation and the glycocalyx layers in the cell?
So we've looked into this extensively, and in the literature there's the presumption that glycocalyx is equivalent to vascular barrier, and this is not true. So if you do an initial insult, you wash away the glycocalyx, but in order to abolish the vascular barrier, you also need to ensure that the junctions between the endothelial cells are destroyed. So it can happen in extreme reperfusion injuries. So there are soluble adherents and cadherents, which are the anchor molecules between the endothelial cells. If you see those go up, you really have a vascular barrier. So the main importance of glycocalyx degradation is that you release the phenotype of the glycocalyx, which is autoregulation, which is hemostasis. The Van Willebrand's factor is inside the glycocalyx. The adhesion molecules, which are embedded inside, so you're going to get more inflammation. So in my opinion, that's the main reason for keeping the glycocalyx intact.
So you also believe glycocalyx degradation is an early marker for organ injury?
Yes, directly related to oxidative stress and directly related to the amount of fluids that you give.
Professor Inz, I have one question about the temperature. You know, you didn't mention the temperature. Normally we cool down patients of 34 degrees. Do you have a recommendation about that concerning microcirculation?
Well, please, I'm a physiologist. It's not my thing to give anything, but we did look at patients, about a small cohort of 8 patients a long time ago, who were cooled to 18 degrees. And there was nothing wrong with the microcirculation in those patients. So the basic idea, I guess, is that you reduce metabolism. But what worries me more is as soon as you hit around 20 to 18 degrees, your sodium-potassium pumps will start to get inhibited, and your membrane potentials will start to depolarize. So I wouldn't be very happy in cooling myself down to 20 degrees, because I think I will have a problem, either electrophysiologically certain. So.
Yeah, sorry. I have also one question to Professor Insen. You in your presentation, you was talking several times that tend to the diffusion distance, to the diffusion problem. From this point of view, what do you think about using crystalloids, which you mentioned already that it's disappear from circulation to the cellular space, extracellular space very fast? What about colloids? Is it not beneficial to use for resuscitation colloidal solutions to keep colloidal osmotic ratio and prevent the increasing of distance?
What a wonderful question.
Thank you.
I wish I could talk 10 minutes on this question. I'm a great believer in using colloids. If hypovolemia is the problem that you want to fix, I believe that starches are a very, very effective, cheap colloid, and I think that the trials which were done in Australia have killed this potentially important product, based not physiologically, blinded. So there's a very nice paper in anesthesiology, which I was honored to be a co-author with, in which you see that if you give a crystalloid resuscitation, you see the, in comparison to a starch in a hemorrhagic shock model, you see that both are equally effective in improving stroke volume and cardiac output, but that saline does nothing to the microcirculation, and you see that the colloids also improve the microcirculation. So the important thing about choosing fluids, in my opinion, is you need a hemodynamic target. If you don't use a hemodynamic target, you do not have benefit from the increased retention in the intravascular space. Now, there's one thing that I'd really like to say about the use of colloids. If you give colloids, what happens is that your hemodilution goes down much more rapidly. So if you're looking at your hemoglobin levels and you give equal amounts of volume, then you will probably hit your blood transfusion targets a lot quicker than if you would crystalloids. But this is exactly why you give a colloid. You give it to expand the intravascular volume. So they say, oh yes, but you give more blood transfusion. Yes. That's exactly why you are doing it, because you want to expand the intravascular volume. So it's a wonderful question, and now people are using gelatins. Gelatins are really a bad idea. They kill your liver. They have all sorts of inflammatory effects. So I think albumin, we don't know what's in albumin. I mean, there are 200 companies that produce albumin. If I ask the company, well, if you take the albumin out, what's left in your bag? They don't know how to answer that. So there are balanced salt solutions. There are all sorts of weird stuff about albumin. So I really think that for perioperative use, a Volu light or Isolite, a balanced starch solution, is a safe, as a physiologist, so not as a clinical doctor. Thank you for your question.
Thank you very much. It was really marvelous answer. Thank you.
Apostolos.
So I have some comments. When it comes the goal-directed perfusion, I do believe that the best way to provide adequate feeding to the periphery as well as head organs is apply goal-directed perfusion. So for me, when I perform cases on MEC, the only parameters that I calculate is not just the classical, like arterial pressure or cardiac output, but the metabolic parameters such as oxygen delivery, oxygen consumption, oxygen extraction rates, and perfusion ratio. And it is well known the relationship between the DO2 and the VCO2, and if we imbalance this optimal oxygen parameters, then we'll jeopardize microcirculation. And if we include the brain as an index and not as a target organ, that means if we challenge the perfusion outcome with the brain, then we have a safety net, and we knew any time, any minute that the periphery is perfused well. When it comes to the macrocirculation, I'm convinced that the core issue of this is hematocrit. So try to avoid hemodilution with using a MEC system. And of course, this is the prerequisite for preserving a good hematocrit in order to provide adequate oxygen delivery, not just by flow, but because of the diffusion, because it keeps the distances short between the capillaries and the tissue.
All right, I think the message has been passed on, and let's finalize it with Ignacio, who is attending from yesterday.
Okay, good morning, everyone. You listen me?
Yes, we do.
Yeah. In our experience, in a little experience from Antea Hospital, Bari, we observe when we do a minimal invasive extracorporeal circulation approach, a reduction for corrective action for goal-directed perfusion. We observe in our experience a reduction for the correction of volume management and a reduction of pharmacologic approach during the conduction of minimal invasive extracorporeal circulation. The question for the audience for me is this. You feel that a reduction of the corrective action during CPB is an expression of a reduction of the invasivity of the minimal invasive extracorporeal circulation approach, is a good parameter to quantify the corrective action during the extracorporeal circulation for validate the minimal invasive approach. Because when we use a minimal invasive extracorporeal circulation, we observe a reduction of the corrective action during the procedure.
Any answer to Ignacio from the panel? I think Mark Bennett. No? All right. So I don't know. No answer for this. Probably it was a comment more rather than a statement rather than a question. That's why. And was not quite clear to understand and give a clear answer to this, Ignacio. But
yeah, Professor. My question is, in your thinking, in your opinion, the corrective action during mini cardiopulmonary bypass is an expression of the reduction of invasivity of the CPB during the procedure in terms of vascular resistance, in terms of GDP?
Well, it's cumulative effect of all these. What we keep saying is that, first of all, MIEC is not just a circuit or a system, it is more a strategy. So if you employ all these, let's say, techniques that we're discussing the last 2 days, probably, if you put it also in the conventional system, your perfusion result would be definitely better. However, if you are using the MIEC system, which has all the advancements in perfusion technology on board, I believe that your perfusion will be optimal, and that's the difference. And this is why we advocate that if you want to have the maximum benefit from CPB technology, you should go for MIEC system, apply a multidisciplinary strategy, and then you will find the best result. This is my answer.
Yeah, I believe.
Okay, thank you. So unfortunately, we need to go on.